Cushing's syndrome is a hormonal disorder caused by prolonged exposure of the body's tissues to high levels of the hormone cortisol. This can stem from various causes, including exogenous sources like long-term use of corticosteroid medications or endogenous sources such as a cortisol-secreting tumor. Causes: 1. Exogenous Cushing syndrome, the most common cause due to prolonged use of glucocorticoid medications for conditions like asthma, rheumatoid arthritis, and lupus. 2. Endogenous Cushing syndrome, less common, arising from the body itself. Causes include Cushing's disease, a pituitary adenoma secreting excess ACTH, adrenocorticotropic hormone, adrenal adenoma or carcinoma, tumors within the adrenal gland producing excess cortisol, ectopic ACTH syndrome, non-pituitary tumors like small cell lung cancer secreting ACTH. Symptoms: weight gain, particularly around the trunk and face, leading to a moon face, and a hump between the shoulders, buffalo hump, thinning skin that bruises easily, purple or pink stretch marks, stria, on the abdomen, thighs, breasts, and arms, muscle weakness, high blood pressure, hypertension, bone loss leading to fractures, increased hair growth on the face, neck, chest, abdomen, and thighs, menstrual irregularities in women, erectile dysfunction in men, mood disorders, including depression, anxiety, and irritability. Diagnosis: initial tests include 24-hour urinary-free cortisol, late-night salivary cortisol, or a low-dose dexamethasone suppression test. Confirmatory tests: once initial tests suggest Cushing's syndrome, further tests determine the cause. These can include a high-dose dexamethasone suppression test, CRH, corticotropin-releasing hormone, stimulation test, and imaging studies, MRI or CT scans, to identify tumors. Treatment: exogenous Cushing syndrome, gradually decreasing the dose of corticosteroids while managing the underlying condition. Alternative treatments may be explored to minimize corticosteroid use. Endogenous Cushing syndrome depends on the cause. Pituitary adenomas, often treated with surgical removal of the tumor, radiation therapy, or medication to block cortisol production. Adrenal tumors usually require surgical removal of the affected adrenal gland. Ectopic ACTH syndrome. Treatment focuses on the source of the ectopic ACTH production, which may involve surgery, chemotherapy, or radiation. Prognosis: the outlook for individuals with Cushing's syndrome varies based on the underlying cause, the severity of symptoms, and the effectiveness of treatment. Early diagnosis and appropriate treatment can significantly improve quality of life and reduce the risk of long-term complications. High yield points. Cushing's syndrome is characterized by hypercortisolism, leading to distinctive physical signs and metabolic disturbances. Diagnosis involves biochemical testing, followed by imaging studies to locate the source of excess cortisol. Treatment aims to normalize cortisol levels, which may involve surgery, medication, or radiation, depending on the underlying cause. Clinical case: Cushing's syndrome. Patient information: age, 32-year-old female, occupation, office manager, medical history, asthma, managed with inhaled and occasional oral corticosteroids, no previous significant illnesses or surgeries. Presenting complaint: the patient presents to the clinic with concerns about recent weight gain, particularly around the abdomen and face, easy bruising, and the appearance of reddish-purple stretch marks on her abdomen and thighs. History of present illness: over the past 6 months, the patient has noticed a progressive increase in weight despite no significant changes in diet or exercise. She reports that her face has become more rounded, and she has developed a noticeable fatty hump between her shoulders. She also mentions frequent bruising, even with minor bumps, and the recent onset of menstrual irregularities. The patient is particularly distressed by her physical changes and reports feeling increasingly anxious and depressed. Physical examination: vital signs: blood pressure 145/92 millihg, heart rate 88 BPM, BMI 31 kilograms per milliliter. General appearance: central obesity, rounded moon face, supraclavicular fullness. Skin: thin skin with easy bruising, wide purplish striae on the abdomen and thighs. Musculoskeletal: proximal muscle weakness noted during the examination. Diagnostic workup: 24-hour urinary free cortisol elevated, low-dose dexamethasone suppression test failed to suppress serum cortisol. ACTH level normal, suggesting possible adrenal pathology or exogenous corticosteroid effect. Abdominal CT scan, no adrenal masses identified, suggesting the possibility of exogenous Cushing syndrome due to corticosteroid medication. Assessment: a 32-year-old female with a history of asthma treatment involving oral corticosteroids presents with symptoms suggestive of Cushing syndrome, including central obesity, facial rounding, easy bruising, purple striae, and proximal muscle weakness. Diagnostic tests indicate elevated cortisol levels not suppressed by dexamethasone, with normal ACTH levels. Management plan: 1 endocrinology referral for further evaluation and management of suspected iatrogenic Cushing syndrome. 2. Medication review. Assess the necessity of current corticosteroid regimen for asthma management, considering alternative treatments with lower systemic effects. 3. Lifestyle modifications. Diet and exercise counseling to address weight gain and cardiovascular risk. 4. Mental health support. Due to reported anxiety and depression, referral to mental health services for support and possible treatment. 5. Bone health. Due to risk of osteoporosis associated with prolonged corticosteroid use, recommend DEXA and consider calcium and vitamin D supplementation. Follow-up. Regular follow-ups with endocrinology to monitor cortisol levels and response to any changes in asthma management strategy. Continued support for mental health and lifestyle modifications. Discussion points: the importance of considering iatrogenic causes in patients with Cushing syndrome symptoms, especially with a history of corticosteroid use. The need for a multidisciplinary approach in managing the physical and psychological effects of Cushing syndrome. The significance of patient education on the potential side effects of long-term corticosteroid use and the importance of regular medical reviews.